Hello, my name is Dr. Diwan S. Raja. Today I will discuss about pneumothorax. So what is pneumothorax? Pneumothorax is a clinical condition when there is air or gas enters into the interpleural space. So air or gas in the interpleural space. What is interpleural space? The interpleural space is a space between the parietal pleura and the visceral pleura. This is the space between the parietal pleura and the visceral pleura, also called pulmonary pleura, same as pulmonary pleura. Okay, we got. So what is the pulmonary pleura? Pulmonary pleura is the red line here. This red structure is the pulmonary pleura or visceral pleura. Same thing. Pulmonary pleura, also called visceral pleura. Okay. And what is the parietal pleura? This is the parietal pleura. The black one is the parietal pleura. Okay, so in our life, these two pleura are just one over another one, are in close contact. There is no gap between the parietal pleura and visceral pleura. Lung has a tendency to collapse. So we have always negative pressure in the interpleural space. That negative pressure always keep the lung expanded. Okay, so interpleural space has negative pressure. Interpleural space has negative pressure. Okay, and negative pressure is essential for the expansion of the lung. So when that negative pressure is lost, then lung collapses. So lung is expanded due to negative pressure, and the interpleural space is a potential space. Okay, this is interpleural space is a potential space. So in a healthy person, there is no interpleural space. It doesn't exist. Actually, the parietal pleura, visceral pleura are in contact. We have only a few ml of fluid in between two layers. So it is a potential space. Okay. Okay, so when it should not contain air or gas, two layers, red and the black, are in close contact. So when air or gas enters in between them, we call it pneumothorax. Okay, so we got the definition of pneumothorax. So here there is pneumothorax. Here air is here. This is the lung. This is the pulmonary pleura. This is the parietal pleura. Parietal pleura. And this red is the pulmonary pleura or visceral pleura. Pulmonary pleura. Okay. So here air entered into the interpleural space, so we have potential space. Now it is a real space. So this is air. This is lung. Lung has been collapsed. This was lung. It has been collapsed. Now here there is air. This is the pneumothorax. Okay, we got the pneumothorax. Here again, this is the pulmonary pleura, parietal pleura, this containing air. This is the pneumothorax. This is normal. This is the potential space. In life, we should not have any space. One layer is coming in contact with another layer. There is negative pressure here, and that negative pressure expands the lung. So if there is air there like this, then we call it pneumothorax. Okay, we got that. Then we will classify the pneumothorax. Classification. Okay, we have different classification. Okay, types of pneumothorax. It may be spontaneous pneumothorax, it may be traumatic pneumothorax, it may be therapeutic pneumothorax. So, spontaneous may be primary, may be secondary. Spontaneous pneumothorax may be primary or secondary. Okay, we have other type of, it may be due to some type of trauma, so it may be traumatic pneumothorax. There is another type of pneumothorax. Suppose a person got the stab injury, gunshot injury on the chest wall, then we call it traumatic pneumothorax. Or it may be just therapeutic or iatrogenic pneumothorax. Okay, these are the types of pneumothorax. So our spontaneous pneumothorax may be primary condition. We have in primary spontaneous pneumothorax, the lung is healthy. Lung has no pathology. This is also called idiopathic spontaneous primary pneumothorax. Okay. In secondary, there is some lung disease. Okay. The lung, there is lung disease. Okay. That is secondary. Okay. So the primary spontaneous pneumothorax, this is found in the young individual, young age, maybe around 20 to 40 years, and young 20 to 40 years. And these persons are usually tall and thin. Okay, why they have more chance of spontaneous primary or idiopathic pneumothorax, we cannot explain, but it is found that it is found in the young individual, and they might have some type of congenital bleb in the lung. So there may be congenital bleb or bulla in the lung. Okay, that may happen. So if this is the lung, if there may be some bulla here, congenital, that may be ruptured, that may lead to primary spontaneous pneumothorax. Okay, the lung as a whole is healthy, just we have the congenital bubble or bulla here that may be ruptured. Okay. That is primary. Secondary spontaneous pneumothorax, we have diseases in the lung. Secondary type, we have lung disease like that of emphysema or any other COPD or any other COPD like that of chronic bronchial asthma or chronic bronchitis, bronchiectasis. So in that condition, lung abscess, there may be pneumothorax, lung abscess, maybe lung cancer, that may lead to pneumothorax. There may be tuberculosis or sarcoidosis that may lead to spontaneous secondary pneumothorax. Pneumothorax may happen due to unpressurized aviation. Pneumothorax may happen due to scuba diving. Okay, in some individual who are not conditioned. Okay, so these are secondary causes of the spontaneous pneumothorax. Okay, we got that. Now we'll find out other type of classification or type, like something is closed pneumothorax. Okay, in that condition like this, the chest wall is okay, there is no air is coming outside the thoracic wall, so this is coming from the lung going to the interpleural space, again it is getting back to the lung tissue going to the bronchus, so that is the closed pneumothorax. It is going out, going in. Okay, so that is closed pneumothorax. Chest wall is not affected, so chest wall is intact, it is not penetrated. Okay, it may be open pneumothorax. Okay, thorax. In that condition, what will happen? The chest wall has some defect, so air get in, get out during inspiration, expiration. Okay, so that is open pneumothorax. We'll add one more, that is tension pneumothorax. Okay, tension pneumothorax. This may happen when there is valve mechanism, either maybe in the chest wall, maybe on the damaged lung, there may be flap valve formation. There may be flap valve formation that permits the air to go into the interpleural space, okay, during inspiration. Okay, air entrance to the interpleural space, during inspiration. But cannot exit during expiration. Okay, so you got, there may be a flap valve formation, maybe here, maybe there, so air is getting in, getting in and air is getting to be expanded, and this is tension pneumothorax. The tension will be increased. There will be hemodynamic instability. Okay, so we have to know in tension pneumothorax. Okay, in tension pneumothorax, what happened in tension pneumothorax? Okay, so there is tension because air is getting in, air is unable to get out, entrapment of air. Okay, tension build up, number one. Number two, shifting of the mediastinum. The structure between the lung, we call the mediastinum, it is shifting towards the other side. There will be tracheal deviation to the other side. Okay, shifting of the trachea and mediastinum. Trachea is also a part of mediastinum. Mediastinum to the other side, to the contralateral side. This side has damage, so this is the healthy side, so it will go to the other side, contralateral side, to the contralateral side. Okay, so that is the tension pneumothorax. There will be hemodynamic instability. Instability. Why hemodynamic instability? Because due to shifting of the mediastinum towards the other side, the superior vena cava will be compressed, aorta is compressed, heart is going to the other side, and blood cannot reach to the heart, so eventually it may lead to heart failure. Okay, so there will be engorgement of the vein in the head and neck region. There will be hemodynamic instability that may even lead to death in tension pneumothorax. Okay, we got the types of pneumothorax. Now we have to find out the signs, symptoms of. We got the causes, then we'll go to the signs and symptoms. Signs and symptoms. There will be pain, sudden pain. Usually it is a sudden pain, and in some individual on very rare occasion, pain may come later. Okay, there may be respiratory distress, so there will be difficulty in breathing, dyspnea. There may be cyanosis, because in case of tension pneumothorax, there will be no oxygenation because superior vena cava and the other structure is pushed to the other side. Cyanosis and abnormal chest movement. Abnormal chest movement. Okay, we got that. We may also get loss of respiratory sound, loss of breathing sound, okay, and on percussion we'll get, okay, on percussion, tympanic feeling on percussion because air inside it, tympanic on percussion. Okay, there may be subcutaneous collection of air, so there will be subcutaneous emphysema, and we must know that tracheal deviation to the other side, deviation, and mediastinal deviation on X-ray, we'll get it. we can palpate the tracheal deviation. Okay, so these are the signs and symptoms of pneumothorax, especially tension pneumothorax. Okay, so we got that signs, symptoms. Now, what are the tests or diagnostic tests? How can we diagnose? Okay, diagnosis by chest X-ray. Chest X-ray, PA view and left lateral view and lateral view. Okay, we can do that. So by chest X-ray, we may do CT scan if it is required. Okay, usually it is chest X-ray can catch it. What we see in the chest X-ray, we'll see white visceral plural line. Okay, finding is white, comparatively white visceral plural line with lack of vascular marking, with lack of vascular marking. Okay, outside the white line, outside the white line, there is the white visceral plural line. Okay, we get that. So outside this line, no vascular marking because there is no lung tissue here. Lung is now here. Lung is now here. This is air. Okay, so we get this is darker in our X-ray. We got the chest X-ray. Okay, so what should be the, and we also can assess that the percentage of pneumothorax. If it is only 1 centimeter, then it is 10%. If it is 2 centimeter, 20% pneumothorax. We can assess in that way. Okay, so we got the diagnosis. Now we'll do management. It should be managed in the hospital setting, in the emergency department. Okay, management. First of all, in case of tension pneumothorax, we should do needle aspiration. Okay, needle aspiration. Okay, then we'll put the chest tube. Okay, we'll give oxygen to that person, to the patient. Oxygen. So that is the way. And in most cases, if it is only 10% or 20%, it may come back spontaneously. It may take few days, maybe few weeks. Sometimes it may not come back. It does not expand properly. There may be scarring on the surface. There may be collection of fluid here, collection of pus here. There may be empyema thoracis. So in certain situation, when there is scar formation, that does not expand properly. Okay, that may be the complication that may happen. So our management is needle aspiration, chest tube placement, oxygen, and it should be consulted with the pulmonary surgeons. So if it is repeated or recurrent pneumothorax, you can do surgery or fluoridesis by tetracycline called minocycline. So it may be required to do surgery if there is repeated pneumothorax. And surgery is done under the video assisted surgery. and the site of bleb may be taken out by surgery. The bleb is taken out. Bleb is taken out. Bleb is or are, blebs are, or the bulla are taken out. Okay, we can use some type of tetracycline on the surface so that the visceral pleura and the pulmonary pleura are adhered together, so it may prevent recurrent spontaneous pneumothorax. And that's all about the pneumothorax. If you have any question, please feel free to ask me. Please share the information with your friends and please support my channel. Please subscribe me. Have a nice day. Bye now.